Hi, everyone. Thank you for coming today. Today we have HBI's Neuro 101 series, and today's speaker is Dr. Mark Richardson for Invasive Brain Stimulation Therapies 101. Dr. Richardson is an MD, a PhD, so he's a neurosurgeon who also has a basic research lab, and that's a brain modulation lab at MGH. So he splits his time 50-50 between the clinic and the lab. He's the director of functional neurosurgery at Mass General Hospital, the Charles Pappas Associate Professor of Neurosciences at Harvard Medical School, and he's also a visiting associate professor in the Brain and Cognitive Sciences Department at MIT. In the clinic, his expertise includes invasive brain recordings in the treatment of a variety of neurological conditions, movement disorders, mental health conditions, and epilepsy. His brain modulation research lab is a human systems neuroscience lab, studying brain electrophysiology and behaviors in the various patient populations that he treats. He came to Boston in 2019. Before that, he was the director of epilepsy and movement disorders at the University of Pittsburgh Medical Center. And his lab, among many other things, has done some pioneering work describing simultaneous cortical and subcortical recordings during speech. They've also done the first study describing biomarkers of therapeutic responses during neurostimulation for epilepsy. So we're really grateful he's joining us today. If you have questions during the talk, as always, feel free to type them in the chat box. And at the end, you can raise your hand and a recording will be available at the end of the talk. So I think we can get started.
Great, thanks so much for the introduction and the invitation to present today. So for this talk with the broad audience, I did something a little different than I've done recently in talks, which was really try to pull back and give a broad overview of the brain stimulation field, which mainly has been DBS, deep brain stimulation, but now clinically also incorporates RNS, responsive neurostimulation. So I'll talk a little bit about the history of that, of the field. There's really a lot of, I think, misunderstanding about the history of DBS and the field in general. But this is a very active area, I would say, in medicine. Really, it's a historical time for how we interact with the brain. And we can treat patients a lot more effectively than we could several years ago. And we're learning really rapidly because of the advent of devices that can stimulate and record in the brain in more comprehensive fashion. So as mentioned, I do functional neurosurgery, which is neurosurgery that's meant to improve the quality of people's life. So if you take a brain tumor out, that improves their quality of life too, but that's something you really have to do. Functional neurosurgery disorders are things like Parkinson's disease, essential tremor, dystonia, epilepsy. They're not diseases that will kill a patient within a few weeks or rapidly paralyze them. But these are diseases that really significantly affect quality of life and steal the identity of patients, really. And so the goal of functional and restorative neurosurgery is to restore quality of life and restore function. And primarily we do that with devices at this stage. So let's talk a little bit about the history of DBS. So, and we'll cover a couple of myths here. So one idea is that DBS is very new and it's experimental. Certainly there are areas of DBS that are still quite experimental, but DBS has been around since the 1950s, and electrical stimulation in the brain in humans was really started shortly after the introduction of the stereotactic frame. So this is a picture of one of the versions of the first stereotactic frame, the Spiegel and Weissach model. And this is how we do it today. Just so you know, we still have to fix the person's head in place during surgery. This is the base of what's called a Lexell frame, which was probably the most popular frame to be developed and used in modern times. We still use the base of this frame. A lot of times the patients will call it a halo. But the way that we deliver a probe into the brain, a recording electrode or a stimulating electrode here, it's depicted along an array of guides that can be set in X, Y, and Z plane. And that targeting was, at that time, was Spiegel and Weissitz, based on postmortem atlas data. Now we base that on the patient's real MRI. It's incorporated into software. And here at MGH, at least, we use a robot to position a holder for the DBS electrode in the proper location, proper entry spot that we'll make in the scalp and the skull. And then we can deliver the electrode with very high precision to the anatomic target. And we expect to do that with a resolution on the order of a millimeter, often less. This patient happens to be participating in research. That's why there's a microphone there. And we'll talk about that at the end of the talk. Let me keep an eye on the time. If any particularly good questions come through the chat, don't hesitate to just interrupt me, because I can't see that with the way I have my screen set up, just so you know. But I'm happy to be interrupted, and hopefully we'll have some good discussion at the end as well. So here, another myth is that DBS started as an alternative to ablation. So it is true that while essentially the field was waiting for technology to catch up, that ablative surgeries like pallidotomy for Parkinson's disease were quite effective and were used often to reduce symptoms. So these, all of the therapies that I'll talk about today don't affect the disease primarily. And this may be one reason they're underutilized, which they are, because they're thought of as a Band-Aid or just affecting symptoms, but they can affect symptoms in really dramatic ways, which is obviously why we think it's worthwhile to do this, even if it doesn't affect the disease primarily. So pallidotomy, let's say, for instance, which is lesioning the globus pallidus, can be very helpful in suppressing symptoms in Parkinson's disease, for example. But electrical stimulation really developed in parallel. So this is, I think, important to point out. And the first applications weren't in movement disorders, but they were in psychiatry, and that's both ablation and stimulation. This is a very famous in neurostimulation world video, which was the first demonstration of what you might call brain control. So this is a fuzzy old video from 1960s, and what you see is a bull with electrodes implanted in its brain. And this person holding a red cape and a radio transmitter is the neuroscientist Rodriguez Delgado. And so he was the first to, one of the first to actively engage in preclinical experiments to control behavior with electrical stimulation. And he was also a bit of a showman, so he jumped into the bull ring and turned the simulation on and off while the bull is preparing to charge, but also went on to do work in non-human primates. And interestingly, the term DBS, which was trademarked by Medtronic, which is the company that had the monopoly on producing these devices that were implanted in patients for decades, really just until about 10 years ago, where other competitors entered the market. But they trademarked the term DBS for the treatment of pain, which interestingly never got FDA approval. So there's some of you may deal or have heard of patients with chronic pain problems from a variety of insults. And DBS can be quite effective. The issue is that earlier trials that were done probably didn't have proper control arms, and now DBS for pain is not FDA approved. It's still actively done in Europe. I think it's really a missed opportunity and one that's been overlooked. These patients can be difficult to help, but that's an open opportunity still for sure. Okay, this is what one of the old devices looked like. So the DBS, the stimulating electrodes are implanted in the brain. There's a connector wire that runs down the neck and to the pulse generator or battery. which is implanted in the chest. And excuse me, the first of these were controlled with an antenna that would just be taped over, and then the patient's holding the controller. And this is what a version might look like today. This is one of the devices that's available. There are 8 contacts. They can be lined up like this, or they can be segmented in the middle, which you can't really appreciate here. There's pretty sophisticated software that can depict a volume of tissue activation. This is a model of the electrical field. The latest version of this can show this in relation to the patient's subcortical anatomy, like for instance, the subthalamic nucleus, one of our targets in Parkinson's disease. And pretty sophisticated controller software. And this particular device has independent current control. So current can be delivered independently and at each of the contacts, and one can shape the electrical field and try to conform that to the patient's anatomy. This is where a lot of people think that DBS started, and it does mark really the modern era of DBS. And this was in ablation procedures where it was realized with existing technology that one could turn on certain frequency of stimulation on a device that's available for implantation and leave it in the patient without having to create a lesion. And I pulled this actually from NIH, NINDS website. This is a history of DBS. It's important to note that throughout the history of DBS, there's been really close interaction between basic science and non-human primates and eventually in humans through DBS surgery itself to co-evolve strategies and models really of how, for instance, basal ganglia works and how that can be modulated by DBS. And when I started in training, people would say, well, we really don't know how DBS works, but it works. It's kind of like a lesion. That wasn't entirely true, and certainly not true now. We'll talk about that a little more. We have a better understanding of how DBS works. But one of the reasons is it's really been developed in parallel with advances in basic science. And Malin, DeLong, and others at Emory were the first to map out in sophisticated ways these circuits in non-human primates. The first FDA approval was for essential tremor. It was actually 1997. The application was in 1996. And it's Dr. Benabid at Grenoble who really pushed the field forward with that initial publication I showed and several more over the next couple decades. Okay, so where do things stand now in the modern era? There are now 5 FDA-approved indications for DBS. The first was essential tremor. That was followed by Parkinson's disease. The VIM there for essential tremor is ventral intermediate nucleus of the thalamus. That's one of the 2. There are more than 2. That's one of the 2 main thalamic nomenclatures that's used. It's the ventral posterolateral thalamus. Parkinson's disease, the targets are subthalamic nucleus and the globus pallidus, specifically the internal segment. And DBS for Parkinson's disease was first FDA approved for later stage disease, even though in practical terms it was used in patients much younger, but still there is this thought through much of the medical community that was really something you would save just until the patient had no other choice. Now we have multiple studies that show patients will be much better off in terms of quality of life if they get DBS once they qualify for it. And that was shown in a study that led to a broadening of the FDA indication for earlier onset disease in 2016. Dystonia is a disease of muscle contracture. So you can think of it as almost a hyperkinetic disorder, whereas Parkinson's is a hypokinetic disorder. Interestingly enough, the targets are the same. That was approved in 2003. OCD and under what's called humanitarian device exemption, which is an exemption that the FDA will grant if it's thought that there aren't enough patients to recruit and perform properly randomized controlled trials. So OCD, obsessive compulsive disorder, was approved under an HDE also in 2009. The target there is the ventral capsule or the ventral striatum. Ventral striatum is also called the nucleus accumbens. And then epilepsy finally got an approval in 2018, and ANT is anterior nucleus of the thalamus. There's a whole lot to talk about regarding DBS and RNS and epilepsy. This talk leans more toward the movement disorder side and a little bit the psychiatric side, because that's where most of the history is. But I do have some information on epilepsy at the end, especially the RNS system. So this was approved in 2013. And unlike DBS, RNS is a closed loop system. So it's chronically recording from the brain on a loop recorder and then stimulating in response to activity that's detected and set. They're triggers that are set by the programming physician. Okay, so I mentioned the idea of kind of scientific progress helping to drive things. This is I didn't cite this publication. This is one of the publications from Toronto, Andres Lozano's group. Number of publications per year, and obviously this takes off after FDA approval, and it continues to rise as we think of new indications and want to understand better how we're helping patients, and very importantly, when we're not helping patients with DBS. Why is that? I don't have a lot of slides on these. Actually, I don't have any other slides on these, but we can certainly talk about it. Depression is one that I meant to highlight specifically. Now I'm realizing I didn't do that. But these are I think the top three other indications that have an extensive history of DBS use. In other countries, it's easier to perform DBS for these indications. With the exception of Tourette's, where there can be sometimes a crossover with OCD or dystonia, it's very hard to do DBS for these indications in the United States because insurance companies don't approve them because they're not FDA approved. But there's certainly evidence to support that they're effective. Question often in these cases is which patients are going to benefit. And I think that's one thing that we do know with the other disease categories. We have a pretty good sense of who's going to benefit and a pretty good sense of how to select candidates. There are other potential indications. There are a number of proposed indications for DBS. These I think are maybe three that are the most promising. Post-traumatic stress disorder, addiction, and overeating. Addiction and overeating are what you might think of that as similar. Okay, what about cognitive enhancement? Can we do DBS to make ourselves smarter? Or some other reason? And the reason I bring this up is because of the really true advances in the field of DBS, there's money flowing into this from the non-neuroscience side. And Neuralink is an example. So if you go on the Neuralink website, this is one of Elon Musk's companies, you can find this information. So this tells you what they're doing. They're developing micron scale electrodes, which they want to implant into the brain. Here's a mock-up of what they might look like. They're going to be wireless. And the very interesting thing, I think, about these types of developments is that the technology is there. The issues, which is why you have these, billionaire engineers jumping into the mix. The technology to produce the devices is there. What to do with it is another, and how you would do that is another question. But they intend to have an app. It's interesting. You go through the website. You'll see there's really they're thinking about brain stimulation differently than we would on the medical side. Where really this is a personalized thing that everyone has a right to. If you want to get a brain stimulator and interact with your brain, then they intend to make that possible. That's my readout. Now they do say that the first applications they want to tackle are medical things like we would typically think of brain-computer interfaces doing. So my talk's not going to cover a lot about brain-computer interfaces because currently, with the exception of stimulating to produce a sensory percept brain-computer interface has really been about decoding brain activity and not about stimulating to do something. So for instance, in a BCI, to control an arm in someone who's paraplegic, the idea is the information is decoded and a mechanical arm moves. Or let's say a voice synthesizer speaks for someone that has locked-in syndrome. So that's their intention. This is the interesting part. What about healthy people? They do think that non-medical applications will be discovered, and their goal is to create these brain-machine interfaces. They're safe and powerful. Okay, so we'll see what happens. But where are we now? Where are we now clinically? So I do think it's important to cover the clinical outcomes for DBS, because anyone who's interested in learning more about DBS should understand that it works very well in these indications for properly selected patients. So what's a clinical data? One thing we know now is that DBS is the gold standard for the treatment of medically refractory Parkinson's disease. So what does that mean? It means at this point, there have been a number of randomized controlled trials that show if you take equally matched populations and half of them get best medical therapy and the other half get DBS, that statistically speaking, those with DBS are much more likely to have an improvement in quality of life, for one. So if you see the last line here, on almost all measures of quality of life, the DBS patients improve, where it's very hard to get improved quality of life. Once you reach a certain stage in Parkinson's disease, the best thing you can hope to do is just maintain that and not get worse. But in DBS, you can actually improve quality of life. And one of the reasons is that patients can gain back, let's call it 4 hours of on time during the day. And you think, well, 4 hours, what does that really mean? Well, there are 24 hours in a day, and let's say 8 are taken sleeping. So 4 hours of being able to do things that you otherwise would not be able to do is a big deal. So that's the type of thing that DBS can get back for people with Parkinson's disease. And we know now that that you don't have to be, you don't have to have exhausted your patients entirely, essentially, to get this. Once you are a motor fluctuator, meaning you're not responding as well to medications, they did work, but they no longer controlling your symptoms as well. These patients can have a roller coaster through the day where they just fall off a cliff or their medicine wearing off. So results are equally good with younger patients. Still, the mean disease duration in this cohort, even though the age was younger, was 7.5 years. It's appropriate often to wait at least a couple years, if not 3 or 4, to make sure that the diagnosis is correct. But once there's no question about the diagnosis and someone is not responding to medication in an expected way, then they are a candidate. So this will play on its own. So here's an example of a patient. No audio in this section. So this is a person with tremor dominant Parkinson's disease. This is his pre-op video. He's demonstrating his symptoms. He's been implanted now, and then the device can be turned on. And what you saw was the controller hanging over the pulse generator in his chest. And you can see this is a really big difference. So when I met this patient in the office, he would bring another shirt because his tremor was so strong, he would sweat through it and completely soak his shirt. What about DBS for essential tremor? The long and short of this is that this works so well, there will never be a randomized control trial because you couldn't convince a patient to enter the blinded arm or the placebo arm. I guess you could think of you could do a crossover, but this is just so obvious when this works or not, because in patients with essential tremor, they have one symptom, it's an action tremor. And so you always see it. And for properly selected patients, this is almost always going to work, literally above 90% chance success rate, and it can drop the tremor, I'd say on average, certainly greater than, we tell patients to be happy if it's 50%, but most of the patients have greater than 60, 70, and many of them have 80, 90% reduction in their tremor. This has been compared to focused ultrasound. So Focused ultrasound is often thought of as a non-invasive procedure, but it's not. It's essentially burning a hole in the brain with ultrasound energy. So it's an ablative technology. It does allow the patient to forego having an implanted device, but it creates a permanent lesion. And there's certainly some centers, like Dr. Cosgrove at the Brigham is an expert in focused ultrasound. I think his data is probably better than some of the data that was used in this study. But broadly speaking, DBS is often safer and a better choice because you can modulate that therapy. You can just turn the DBS off and you don't make a permanent lesion. It's also easier to treat both sides at the same time, which essentially can't do. Well, some people are starting to do it, but traditionally, lesions aren't done bilaterally and simultaneously. Here's an example of what this looks like in the operating room.
Practice the drink again. Yeah, okay, hold that straight out in the air again. And Danielle's going to turn the simulator back on. You keep holding the water bottle. What does that feel like, Larry?
It's a real blessing. Look at that. Perfectly still.
Larry, what do you think about having surgery awake like this?
I think it's marvelous. I'm really shocked that I could actually do this and have the surgery at the same time. I never thought it was possible.
Well, you're doing a great job. Okay, we'll get ready to do the second side now, okay?
That's just marvelous. That's truly a blessing.
Okay, well, obviously I'd like to show that video for several reasons, but it does highlight the fact that for some patients, being awake in the operating room is not that big a deal. And those patients are particularly well suited to help us with our basic neuroscience research. And I haven't put a lot on that in the talk. I have a slide at the end and happy to talk about that more with questions. But that gives you a sense of the environment in the operating room. And with the central tremor, you really should see it go away. And that's one reason why I favor always doing those cases awake. Having said that, it's important to know that we don't have to have the patient awake to do DBS. So at least half of our patients now, DBS is done asleep under general anesthesia. In that case, we use MRI guidance and not physiological guidance. So we can use brain recording and test stimulation when we have the patient awake. What about dystonia? So dystonia, there is good evidence for improvement, and there are different types of dystonia. Cervical dystonia is one you might have heard of or have seen someone with, or torticollis. It's this contraction of the neck muscle like this, and some people have to walk sideways because their neck is so contracted, and with DBS that can straighten out. So there's good evidence that this works even in
My name is Stephanie
I'll just let you
Christian.
see.
I'm 63 years old. My symptoms are shaking of my right arm. I can't write. My voice is shaky. My neck, I got a bobble here. It goes up and down.
Okay, and what treatments have you done?
I got Botox in my neck, the back of my neck, and my shoulders. No treatment on my arm or anything.
Okay.
I try to eat 3 meals a day, but I get choked on my food. So it's hard to finish a complete meal. Oh no, I've been taking vitamins, nutrient shakes. Yeah. Good morning. My name is Stephanie Christian. And I'm having deep brain stimulation. It's more
Okay, great, thank you.
I'm going to pause the video here for a second. So this lady has dystonia. She had dystonic head tremor, and also when she was in the yellow shirt, you heard a little bit of labored breathing. She maybe had a component of laryngeal dystonia too. So the muscles that control the larynx can also get dystonia. I was so concerned about her and her breathing, how it progressed when she showed up for her surgery, that I called one of the ENT surgeons to come evaluate her and make sure it was safe for us to still do the surgery, because I was so concerned about it. And we proceeded. Oh shoot! Let me fast forward through the video. And we'll just see how she did.
Oh,
Stephanie, maybe you could just tell us your name again, how long ago you had surgery?
okay. I should put my teeth in before I tell you.
Oh, that would optimize the video, wouldn't it? That's okay. It'll,
Keep your mouth shut.
there's a big difference.
Oh, okay. It's been 2 years now, and I couldn't write my name or anything. I was just
Right.
shake like Parkinson's disease.
Let's see your hands now look pretty good. Can you hold them out in the air?
But my hand,
Yes, please. Thank you.
I couldn't do that.
Oh, I know.
Okay. Oh, there's some old UPMC propaganda. I've got to edit that one. So I think you get a sense that some of these surgeries can be real game changers in terms of quality of life for some of these patients. So this slide was out of order. She also had some components of oromandibular dystonia. It's something called May syndrome. And DBS can work very well for May syndrome in my experience. Okay, I did figure out how to see the chat, and so I'll see a question I'll answer there in just a second. So, okay, what about OCD? So that's the fourth of the five FDA-approved indications. So OCD, the experience worldwide is not great, which to just point out. It's the criteria for undergoing DBS for OCD is pretty extensive in terms of the severity of the disease. So one of the issues here is some of these patients cannot leave their home to undergo the clinical testing that's necessary or make it through all of the criteria. So that's some of that it's necessary, obviously, that the correct patients are selected. But I do think that's one issue in OCD. It's the nature of the disease. It just makes it very hard for these people to get to medical care. There are two targets. I told you about the one that's approved in the United States. There's arguably better evidence for the anterior part of the subthalamic nucleus. So we use the posterior part, which is the motor territory. And I'll talk about this a little more in a slide at the end, but the differences here. But the front part, the more kind of limbic connected part of the subthalamic nucleus, has been used in Europe to treat OCD in a smaller number of patients, but it's worked well. There's one center who did a head-to-head comparison. They actually implanted patients in both targets and went between the two and also at the same time. They didn't see a difference between the two. And here's the data. And this, I'm just showing you data from one trial, but I think it summarizes the data that's out there pretty well, which is that that DBS, it works for OCD in properly selected patients. And so at MGH, we do probably 2 or 3 of these cases a year, and that's actually a lot. But there's certainly more, relatively speaking, that's a lot. There are certainly more patients out there, but when a patient gets all the way through the process and is a candidate, and these patients are reviewed at MGH by the Psychiatric Neurosurgery Committee. It's a longstanding committee, a multidisciplinary group that reviews these cases. Once patients make it through that process, we're very excited to try DBS because they have really exhausted every other possibility at that point, and yet still have the potential for, I think, significant improvement. So, like I said, we're very happy when those patients can make it through the process. I'll show this is the kind of ran out of space on the slides. This is the only slide I have about connectomic DBS, and this is work of Andy Horn, who's a new faculty in the Harvard system, with primary appointment at the Brigham, and then secondary appointment with us at MGH. And he and Mike Fox have done a lot of work in this area, and I'm sure Andy will be presenting in venues like this, and I know Mike has. The point of this is that what I've talked about so far, and we'll continue to talk about, is the electrophysiology. It's the brain recordings and what we can learn from directly interacting with the brain electrophysiologically. And there's a whole nother set of information in the MR imaging, and not just the patient-specific imaging, but as a result of things like the Human Connectome Project, normative atlases of fiber pathways in the brain. And so what Andy and others have done in a number of disorders, but this is, I think, a good depiction, is to map the placement of DBS electrodes relative to the pathways that connect different brain regions. And we know that some of these subsystems have a role in specific symptoms of different disorders. And in this case, what's being depicted, this is one of the images from one of their recent papers, is that there is overlap between the pathways that project through what seem to be two very different targets, the anterior subthalamic nucleus and the ventral striatum. There's a lot more work to be done in this area. In my own lab, we're just getting started here to try to incorporate this with our physiology data. Okay, DBS for epilepsy. Just switch gears here. Epilepsy is a different beast, obviously, because of the way the disease presents in the brain, and I'll talk about this more in a minute. One idea about how symptoms arise in the disorders I've talked about before is a problem with over-synchronization of different brain areas. That's a simplistic way of thinking about it, but it's a good general framework. In epilepsy, you have that problem to the max, where there's just such uncontrolled synchrony, and then in a generalized seizure, it spreads to motor parts of the brain and onward, patients lose consciousness. So how do you target brain stimulation? I'm not going to talk about the number of open label trials for doing DBS in, for instance, the hippocampus. This is the study that got FDA approval, which is anterior nucleus of the thalamus stimulation. So this is part of what's classically thought of in Pappas circuit, connection of frontotemporal, thalamic, reward areas. And a lot of epilepsy, just the incidence of temporal lobe and frontal lobe epilepsy is probably higher than other areas. So there's one reason why this target was chosen, and a number of historical reasons. Take-home message from this slide is that this can work pretty well. These are patients that are highly refractory to medication. So the definition of drug-resistant epilepsy is failing just 2 medications. What most community physicians, neurologists will do will cycle patients through, I don't know how many, way higher than 2 before they'll get referred to think about surgery, even referred into a comprehensive epilepsy center or an academic center. So most of the patients that make it into a clinical trial like this have failed 5 medications, for instance. And this is not so in epilepsy surgery, if we can find a seizure focus and take it out with resection, we always want to do that because it's potentially curative. So you can cure epilepsy with surgery, but not all types. And so this trial recruited people with focal epilepsy, but who for one reason or another didn't want to undergo a resective surgery. And there's some variation in the data. But the long and short of it is you can modulate broad brain circuits and tampen down seizure activity and get pretty significant drops in seizure frequency, which make this very worthwhile for the patients, even if they're not seizure free, because of the quality of life improvement. And we'll talk about RNS next. So how is this different? The RNS system has a sensing capability, and it was the first FDA-approved bidirectional brain-computer interface. So, and the only one still. So there's some added benefit here, which chronic recordings and what we can do with those. Let me show you how this works. So in this case, as you saw from the cartoon before, the pulse generator, the stimulator is implanted in a spot in the cranium. So basically we take a piece of bone out, put a titanium tray there that holds the device, it snaps in there. And then there's a direct connection to the leads in the brain. And the reason for this is to reduce the noise that would be picked up if you had to run that through a connector wire and into the chest. So for epilepsy, where you need really quick response times and as clean a signal as possible for seizure detection, this makes a lot of sense. It works pretty well. You might look at that and say, ooh, I don't know if I'd want to have one of those, or what your reaction is, but I can say that these are tolerated very well by patients, and you don't know that this is implanted. So here's a person with an implanted device. So here's a telemetry wand. She's holding this up to the device. It's in her case on the left side of the back of the head. There's a laptop that comes with the surgery. Data is downloaded in the laptop. And then we ask the patients once a week to upload that into a cloud-based server that's hosted by the company that makes the device, NeuroBase. And then physicians have access to that. So I can finish this presentation, I could log into the patient data management system, and I can see the snippets that were recorded on the device of seizure activity and assess various logs of what the device is doing. And then this data can be reviewed with the patient in the office with clinician. The quote from this patient who was written up in a news story, but this is someone with these leads are in the bilateral hippocampi, so it's bitemporal epilepsy. You can't operate on that, or you get a patient like HM. So if we can take out the hippocampus and anterior temporal lobe on one side with relatively little morbidity, little cognitive change. We can't do that on both sides. So this is someone without this device would have no other options beyond medication, and it's been really life-changing. What's the data look like? It looks pretty similar to the anterior nucleus data. It's a little better. And so the natural question is, well, why would you go through the trouble of recording and downloading the data if you could put it just put a DBS in and turn it on what's called duty cycle simulation, so it's always on. And one reason is that with these chronic recordings, we do expect to get better over time in terms of efficacy. And there's some additional advantages like the personalization, adjustment over time, having the objective data. So it's one thing to hear the patients report about their number of seizures, or they may say, well, I don't know when I have them, they're at night. The device will record and should give us that information. It's helpful for adjusting medication. So for instance, some of these patients are still on a lot of medications. If you drop a medication, there's no change in the electrophysiological activity, then you might make a decision to remove that medication, which maybe has some side effects. And there's very interesting data, which I didn't make a slide for, but I'll tell you that everyone has a certain cycle to their seizures. And this has been referred to as multidian, which means multi-day. It's not the same for everyone. You know, it could be a few days, could be a few weeks, and then there can be cycles within cycles in terms of seizure severity or type of seizure. So this is information that is potentially extremely helpful for patients. Even if they can't interact with their own data at this point, it's possible to tell them when it might be safe to drive even, or it's certainly safe to do other things, or when they can expect to run into a cluster of seizures. Let me stop there and look at the questions just so everyone doesn't fall asleep. I saw one question on tinnitus. This is very interesting. So there has been a clinical trial for DBS and tinnitus, and the target was a caudate. That was done by one of my DBS mentors, Paul Larson at UCSF. I'm not sure if that work is going to continue or how. It looks like one can modify tinnitus. But I think just the one group was working on that. So that's a limitation. So I'm not sure is the answer to that question. I don't have an update on that. It sure seemed like there was reason to believe that DBS could be a potential treatment for severe tinnitus. Let's see, does this work best for well-chosen candidates only because of the accuracy of their diagnosis of their neural symptom-based metrics, project response to DBS? I'll assume that's for movement disorders. Accuracy of the diagnosis is critical. And then beyond that, so for instance, Parkinson's disease, not everyone has the same Parkinson's disease. You can have tremor dominant Parkinson's disease, for instance, and you can have rigid akinetic. That's maybe one of the most basic ways if you want to just bifurcate Parkinson's disease. And so it's a myth that DBS only works well to, for instance, control tremor. For people who don't have any tremor, but they can hardly move, DBS can work just as well. It doesn't allow for as dramatic videos, so you don't see it as much on the internet if you're a patient. And then there are things like freezing of gait, which depending on the reason for freezing of gait and whether it responds to medication, might not respond to DBS. So short answer would be yes, there are also symptom-specific considerations. Response to medication is the biggest predictor, though, to make it simple. If the symptom improves with medication, it should improve with DBS. What DBS does is it stops a kind of up and down cycle and takes people back to more slowly fluctuating. So the idea is it sets a clock back on their symptoms. Interesting question about, beyond depression. Yeah, I left out my depression slide. Before we move on, though, let me just mention something about depression. Helen Mayberg gave a talk as part of an MGH Neuroscience Day. Recently, it's been a few months ago now. If you're interested in this area, when you go through and read her work, it's very consistent, and the studies that she's executed at each spot where she's moved in her career have had similar outcomes. And so I am a believer in the idea that DBS will work for depression, but it's very important to do that in a thoughtful way. And there, the connectomic strategy does seem to be critical. The question was about what about bipolar depression? There have been patients treated with, actually that's about bipolar disorder, I think, and schizophrenia. I would say the field probably feels like we need to solve the DBS for depression problem first before moving on to things like schizophrenia. There's a history of attempting to treat people with schizophrenia historically, and there are not a lot of, you can't find really benefit. And if you look at the early data for these other diseases, you find that, oh yes, it did help with depression. I think schizophrenia, it could be that I'm missing something in literature, but I think we're further away from that. I'm very biased. I think brain stimulation could be used to treat anything where we understand the underlying circuitry well enough, and we understand what stimulation is doing. Where do non-invasive techniques fit into the picture? Let me also just check the time. The problem with non-invasive, from my perspective, is that it requires you to go to someone's office and do it. And DBS, it's with you. So that's my best answer for that now. Let me see what else I have here. Okay, well, what about chronic recordings in DBS? So there is now a device made by Medtronic that can record. It doesn't record all the time like the RNS does, but it's being implanted in clinical trial. MGH is participating in that. We're using, and it's FDA approved, so we're using the recordings to help make clinical decisions in the programming, but it does not have a closed loop function available. That's the FDA is not allowed that to be unlocked. But the current clinical trial is meant to show that adaptive DBS or closed loop DBS is helpful. And so I think this will, we will see this happen in the next few years. The device itself will make adjustments based on electrophysiological biomarkers, and the physician will make medication adjustments. And then what we really want to get to is the Neuralink type idea, where this is intelligent adaptive DBS. So we really use AI technology, and the device can teach itself what to do. And maybe it can even make recommendations about when to take or reduce medications based on physiology. One of our collaborators wrote a very nice review paper on this a couple of years ago. And this is one of the things I love about my practice, being able to work with patients in these different groups with different devices and different opportunities to record and stimulate in the brain, that I think there's a lot of opportunity for therapy in one disease to be informed by what we can do in another disease.
Remember, like,
Yeah.
the
Right, the
companies,
special
like
request.
if it comes up, like as a manual request, if it comes up.
I got him. Okay. We just have a couple. So adaptive DBS is here in the experimental realm and humans. So this is a group. This is an Oxford group, and they did this with an external device. But yeah, time.
Oh, no. I wanted to add some questions. Thank you so much for the wonderful talk. I think we're good on time. We still have 15-20 minutes for additional questions. So if people want to raise their hands, please feel free. I wanted to share some questions that people shared during the registration. One interesting question was about the idea of DBS in early onset ALS. And the person was asking, is it possible stimulation could delay the worsening of symptoms, or that it could actually worsen symptoms?
Well, both those things are possible. I think there's not a, at least I can't generate a good hypothesis for how DBS would help in ALS, with exception that a version of the device I just talked about, which is the sensing-enabled DBS, has been used in ALS patients as a brain-computer interface. So basically what that group did was not to wait for some of the fancier technology, but to use what's available, and with a cortical electrode just placed on the brain surface, they could use the onboard computing that's currently available in that device in closed loop fashion to essentially allow the patient to spell words. So far if you, to make an analogy to Parkinson's disease, even though there was a lot of hope potentially that chronic electrical stimulation could slow down the disease, could slow down neurodegeneration, there's only one study that's ever shown that that DBS can slow down a symptom progression, and that's tremor. There really isn't any evidence for disease modifying effect.
Thank you. We had a lot of other questions. One was if you could talk a little bit about targeting DBS in major depressive disorder, the brain regions that you target and how you would think about that. I think you talked a little bit about it, but if you could share a little more.
No problem. Yeah, the target with the best evidence is called the subcingulate white matter. So initially that was thought to be a gray matter target, but there's a lot of accumulating evidence that for neuropsychiatric disease, it's really pathway stimulation as opposed to a specific nucleus that needs to be stimulated. And that makes sense, perhaps, when you think about how some mental health disorders present, although in some cases it can relate to a focal problem. for the most part, multiple brain regions are involved. So you have to think about a way to affect more than one region at a time. Other targets have been, there was a lot of interest in the median forebrain bundle, which passes through the midbrain, where there was some rapid response. One of the European groups published on this. I think that, not sure that that data is held up. The lateral habenula is another target. The nucleus accumbens is a target. And I should point out that the two randomized controlled trials for DBS and depression failed. And one is for the subcingulate white matter. It's thought that potentially that trial was stopped early, and that if analysis had been allowed to continue, there would have been at least some significant subgroup benefit, but it was halted essentially for financial reasons. The company that sponsored that, St. Jude, made a calculation that there wasn't statistically high enough chance for them to get FDA approval, and so they just stopped funding it. And Medtronic did the nucleus accumbens trial, and there, like all other diseases, there are a number of phenotypes. And so phenotype selection does appear to be important, a differentiator. And for instance, if one's going to choose the nucleus accumbens versus subcingulate white matter.
Another question I had was age. Has this been studied in patients of different ages, and are there any interesting trends noted there?
DBS has been used across the age spectrum, and RNS. So for instance, RNS is not approved for pediatric use at all, but we are using it now with efficacy in kids. For Parkinson's disease, it works just as well in early onset Parkinson's as it does in later stage Parkinson's. Same thing for dystonia. One of the most satisfying cases that one can do as a functional neurosurgeon is to do DBS in a child with dystonia who is otherwise just literally wrapped up in a wheelchair. These people often have above average intelligence, and DBS can essentially, relax their bodies and allow them to walk around and to somewhat completely normal in terms of their motor function. So there's certain genetic subtypes of dystonia that respond well, and those are often picked up, in childhood. So that's a differentiator that's maybe not just related to age, but DBS can work very well for someone who's had cervical dystonia their whole life and no one ever told them about DBS. And they get it when they're 60. So I think short answer would be no. I'm not aware of specific age. If you have a disease, whether you're younger or older, does not necessarily predict response.
It's really interesting and heartening to hear about the pediatric applications and what a difference it can make. I think we have some more questions in the chat as well. Let's see. Jeff asks, I'm assuming there's variability in stimulation parameters that work over time between patients, et cetera. If you had to guess, what do you think is the strongest predictor of this variability? Difference in symptoms, anatomy, corrosion of electrodes, et cetera. And also for movement disorders, do you think using electrophysiology signals in closed loop, did you start to talk about this closed loop, would outperform using behavioral signatures, or at least provide additional actionable info?
Yeah, so for the first question, I don't think it's corrosion of the electrodes or scar. And so one thing that's important there is to differentiate this type of what we would call macro electrode. These are pretty big, and we think they should, this is theoretical, but I at least think that we would benefit from smaller electrodes that could cover more of the target, and we could think about which to use, and the DBS will eventually look different than this. But for the time being, these electrodes don't make much of a glial scar. That's been seen in postmortem tissue. So it's unlike if you read studies about other types of BCI that have fine electrodes or single unit recording. There you do get a scar problem, but in DBS it's not an impedance issue or scar corrosion, something like that. when there's variability, it's variability in the patient's disease, either their progression, so rate of disease progression if it's a neurodegenerative disease. Certainly there can be differences in anatomy. Everyone's Parkinson's disease isn't the same. So just even though it's a little like, taking a hammer to every, to a nail, not all the nails are the same. And with regard to using the electrophysiological signal, yes, I do think those will outperform behavioral signals, even though they certainly could be used in conjunction, because ideally, the closed loop device wouldn't respond to a behavior, it would predict a behavior. And I do think we'll get there in terms of, let's say someone is relatively, or let's say that they don't have a tremor. Let me think about this a different way. Actually, this is one of the slides I was going to show. For instance, so this slide, this group used a signal in the thalamus. So the actual tremor, there's a signal that corresponded with tremor in the EMG, and they triggered off of that for their closed loop. Another way is to trigger off the intention to move. So in essential tremor, it's an action tremor. So if the person's saying there's no tremor, if they go to, drink a cup of coffee, it's like this. And so when the intention is to go pick up the cup, then the device switches on and there's no tremor. So that's a pretty simple example, but I think you can think of other symptoms, and I do think that we'll get to the point where we have the ability to predict a symptom onset, and so we don't have to wait for the symptom to happen. And that's the holy grail in closed loop for epilepsy, because now the way the device is designed to work is that a seizure happens and you detect it as quickly as possible and you simulate. But it'd be much better to detect when the whole system is moving towards a pro-seizure state and do whatever the stimulation is that's required. And it may not just be cranking it up, it may be doing it in different locations or alternating frequencies or locations or something like this. So the parameter space, even on the existing devices that just have a few channels, and compared to what's available on the bench, non-sophisticated hardware, the parameter space is massive. And so we have a lot of work to do to optimize how we choose parameters, and there's a lot of work to do there. Let's see, maybe all in the chat. Maybe I'll try to motor through the next few slides. I don't have very much. Let's see, this is the same. I do want to point, this is interesting. So this is a closed loop system that can work off telemetry now. And this is Phil Starr's group at UCSF who's demonstrated this. So the patient can go home and they can have a tablet. And with this research version of the Medtronic device, the device reports the brain activity, there's offline computing, and then a control signal is delivered back to the patient. And obviously the goal will be to get the computing on the device at some point, but there's a proof of principle of this type of thing in movement disorders. I'd like to always include this slide, which is kind of, how do these things work? How is it that we can do this for different symptoms? And it's important to remember that the brain is organized in basal ganglia, thalamocortical loops, and interactions of these regions drive all of human behavior. And so the extent to which we can understand these circuits and the temporal dynamics of the neural activity there, the more likely we are to successfully apply brain modulation techniques in any of these circuits. This is also an important one to show. One of the ways that we think DBS works is to break up pathological synchronization. This is again Phil Starr's group, who were really the first group to pioneer the use of electrocorticography in the operating room. So this is putting an electrode on the brain surface for no benefit to the patient, purely a research opportunity. This has been demonstrated to be safe. Patients obviously consent to this. And this is basic science work that's done in the operating room. In this case, the group turned off and on the DBS while recording from the cortex. And what they saw with the DBS off is that there's pathological coupling between different brain rhythms at the cortical level. You turn DBS on, the phase amplitude coupling drops along with symptoms, and then it rebounds after you turn the DBS off with the symptoms. So that's shown here in these spectrograms. And then what you're seeing on the image below are these is a CT scan merged onto the MRI, and these are artifacts on the brain surface. In the burr hole, you see this line here is where the DBS lead would be going in. There's a small 14 millimeter opening through which we can insert these strip electrodes. I talked about the ability to conform the electrical activity around a target. So this is a relatively new advanced segmented lead. I think this is the last slide, which really just is an introduction to the idea I just talked about, which is using the operating room to learn more about how the brain works and different behaviors. And so for when it's appropriate in a given patient who is obviously consented, we'll spend extra time to do a behavioral task while we have electrodes in. And we can also do this outside the operating room. We just have less access. You know, through some of the newer devices, we can record brain activity, but here we have kind of maximal access. We can record micro ECOG even from the surface. We can record single units from the DBS target. As a part of the clinical procedure to do this, to collect at least the subcortical recordings. In our case, we're interested in the role of basal ganglia in speech production, one of our interests, and so we can have the patients listen or read words, and then we can measure their speech and record their speech while we're recording from cortical and subcortical brain areas. So aside from, well, DBS is the only opportunity, that's not entirely true depending on what electrodes you use. DBS is the opportunity where we have the most access to basal, to subcortical structures and the cortex at the same time. For patients that we have implanted in the epilepsy monitoring unit, some of you may be familiar with that type of cognitive neuroscience work, where we're mapping the seizure onset zone for potential resection or to decide where to put the RNS. We also have the opportunity to run these types of experiments and record from the brain. This is an acute setting, the OR, that's a subacute or semi-chronic setting in the epilepsy monitoring unit. They're there usually for at least a week. And that's it. So I'd be happy to take any other questions. There are a number of other things I could tell you about that are new in brain stimulation, but hopefully that was a decent starting point.
Thank you so much. That was really a fantastic talk. It was really wonderful seeing the videos of the before after of some of the treatments. I just wanted to, unless people have any more final questions, I wanted to end on a big picture question. Just if you could think about, the next 5 or 10 years, what are you, you shared a little bit about opportunities that your lab is pursuing, but what would you say you're most optimistic or hopeful about in terms of making, additional treatment discoveries?
Right. So let's start with DBS for Parkinson's disease. So this works very well for most people, but not for everyone. So I think we haven't hit the ceiling in terms of what we can do. And so we're constantly thinking about how to improve DBS. So I think over the next 5 years, we'll continue to see improvements in, for instance, the treatment of Parkinson's disease. I would like for that to take the form of being able to, in a more targeted fashion, treat specific symptoms. And I think closed loop DBS could help us with that. I'm not sure if within 5 years we'll be implanting cortical strip electrodes to help monitor other symptoms, but I do think that will eventually become part of DBS. And I think you can take that analogy in Parkinson's disease and apply it in the other disorders. We touched on depression. I continue to think there's a real opportunity there. It's not clear to me how that's going to progress. Getting a new therapy FDA approved is very difficult because of the expense. And a device company has to think that they're going to make money off of the new indication in order to fund it, or you have to build your own device from the ground up and do it and get around existing patents, for instance. I think personally, there's a lot. One thing I just mentioned briefly, DBS for addiction. I think there's a huge potential there for using closed loop signals. And so I think that we will see that eventually. Related to epilepsy and the use of the RNS device over the next 5 years, I think there will be a lot of improvement in our understanding of how to use those signals, because I could do a whole other talk on the challenges to optimally use all the information that one can obtain from the RNS device. But we are making progress there. We have a large project in the lab to essentially build our own analysis platform for that data, and we're not the only ones that are doing that. So there's a lot to learn there. I think we will make significant advances in the next 5 years in how we use RNS. That the hardware will also be upgraded, so we'll have more than just 2 leads. I didn't really highlight this enough, but the device only has 8 recording channels, so you can put 2 leads that have 4 contacts each. In the next 5 years, that will probably double. That would be very interesting. Also, it doubles the data, so it doubles the data challenges. And it takes a lot of time to interpret that. So I think we'll see better clinician interfaces, for how to interact with the data. And another important thing that I hope will evolve with closed loop DBS is it gives, and RNS. Now there's not a great way for the patient to interact with the data, but I do think there's a lot of value to that. And I just, in preparing for the talk, I clicked through the Neuralink's website, and I showed some of those screenshots, and I hadn't looked at that recently. And I really was struck by their emphasis on people interacting with their own brain data. And I do think that's coming for sure. And I think even our patients will be able to do that in the next 5 years. And they should. All of these technologies have an underutilization problem. And I'm not saying that just because I'm the surgeon. There's research that shows, for instance, 10% of people who would benefit from DBS for Parkinson's disease actually get it. We know of people who would benefit from epilepsy surgery, less than 5% of them, get any type of surgery. And I think I'm very hopeful that one of the ways we can overcome this problem, which has been described by probably many people, but an ethicist at Stanford named Hank Reilly, as a Frankenstein problem, where people we have this cultural depiction of brain stimulation, electricity in the brain as something that shows up on Halloween or somewhere else. And the more we can have people interacting safely with their own data in the brain, I think it'll help educate the broader community about neuroscience. And lastly, we have a patient engagement strategy in the lab where we're trying to actively incorporate patients into our work in terms of their feedback about the whole experience. And the ultimate goal of that project is to provide the patients with an opportunity to make a contribution that is outside of the potential clinical benefit they would get, and to really take an active role and contribute to neuroscience, to kind of flip that the bad parts of the disease into something good that's beyond their clinical care.
Wow, that is really exciting to hear about, really broad-ranging impact. I think we have one final question in the chat, if we can just go for that. Ovidiu asks, what type of neuronavigation imaging do you do to guide the placement of electrodes, DTI, fMRI, structural MRI? What would you need to improve?
Yeah, so for DBS, we just use structural MRI. In epilepsy, we've often recorded from the brain in an intracranial monitoring procedure, so we have a readout of the brain activity. But for these other disorders, we just make an assumption about the anatomic and functional brain target. And then for a sleep DBS, we're using real-time MR imaging. It's just structural. In awake DBS with recording and test stimulation, we still, as the basis, use structural imaging, which we try to confirm with electrophysiology. I touch on the idea of using DTI, tractography. So far, that's mostly been done in retrospective fashion, but in some of the recent clinical trials, people have incorporated prospectively the use of tractography. So that's something where, you know, there are advances being made. fMRI, there's some work in epilepsy to use fMRI to help localize a seizure onset zone. That has really only been specific to certain centers. So that's not a tool that we use. But it's interesting thing about MEG is used also in epilepsy, but in movement disorders, the answer is just structural MRI.
Thank you so much. So I think we are out of time, so we'll wrap it up. So thank you so much for taking the time to be with us and to share your really fascinating data. And also thank you to the audience for really interesting questions and discussion. And in a couple of weeks, we'll have Brain Rhythms 101 with Dr. Sydney Cash, if you want to tune in for that. Thank you so much.
Thank you.
Thanks.